webinar. This is our 22nd webinar. So you can imagine counting from number 1 up to number 22. And today we are going to be focusing on Africa. So it's a pleasure to have our colleagues from Africa who are going to serve as panelists today to talk about their experience, the issues, the challenges that they're actually dealing with in Africa in terms of addressing the COVID-19. So as usual, we're going to have our first panelist presenting, and then after the first panelist, we're going to have our second panelist. Whilst they are presenting, I would like to invite you all to please provide your questions and comments using your chat function. And later on, I'll actually go through your questions and comments, and I'll post these to our two panelists. And my colleagues are going to send some details for those who need professional enhancement credit. They will provide some details in terms of how you can send through your professional enhancement education forms. So without much ado, I would like to introduce our first panelist today. Our first panelist is Dr. Yimtubezinash Woldea. She is an associate professor at Addis Ababa University in Ethiopia. So she is specialized in medical microbiology. I've been working with Yimtu, so everyone calls Yimtu. I've been working with Yimtu over the past many years, mainly focusing on research ethics capacity building in Ethiopia. So it's great that we have Yimtu joining us today to talk about experience. So Yimtu is also serving as the lead of the incubation hub of the Center for Innovative Drug Development and Therapeutic Trials for Africa, which is at Addis Ababa University. And she has worked on numerous projects as both a researcher and also as an advisor. And she has been mentoring junior researchers over the past 20 years. She has mainly been working on infectious diseases. And she is currently serving as the co-chair for the IRB, or the Institutional Review Board, at the College of Health Sciences at Addis Ababa University. And she also serves as co-chair for another research ethics committee in Ethiopia. So I will now welcome Yimtu to go ahead. Over to you, Yimtu.
Thank you so much for the introduction, Paul, and thank you also for inviting me to be part of this important webinar. So I'll start my presentation and then share some insights. So as Paul said, this is the longest name even for Ethiopia, so everyone is welcome to call me Yimtu. So I'll just start by giving just a short overview of the status of COVID in Ethiopia. This is as of 19th April. So we've had 2.5 million tests done, and our total cases are 243,631, with a total recovery of about 74%, and we have active cases like 59,592. And total deaths is 3,392. So looking at generally at Africa, we are in the top 5, and Ethiopia is in the fourth, on the COVID status. And then, of course, in the East region, Ethiopia and Kenya seems to be driving the drivers of the pandemic currently. So especially now, this the last 1 month or so, we are seeing an increment even though we have a limited capacity of testing. With nowadays we are testing 8,000 or 7,000 daily. So out of those, we are seeing more than 20% positivity. So how is COVID vaccination unfolding in Ethiopia? So we had the first case report last year on 13th March 2020. And at that time, among other, many initiatives, what was done was having an emergency, a state of emergency, where we had certain restrictions, but not complete lockdown. And then that lasted for 6 months. And another thing, just to point out some of the big things that were happening at the time, was increasing capacity of laboratory diagnosis in COVID. So in 3 phases, from 0, it was possible to bring it to more than 60 laboratories that could diagnose COVID-19 in Ethiopia. And then on 7th March 2021, we received the first COVID doses, vaccine causes 2.2 million COVID-19 vaccine doses from COVAX. As you know, COVAX is a collaborative, an initiative that is an international solidarity between CEPI, Gavi, and WHO. So after receiving this 2.2 million doses, the vaccination has been launched exactly at the anniversary of the first case report on 13th March 2021. So it was launched according to the national COVID, the national deployment plan, prioritizing healthcare providers, and then those who are older than 65 and those with comorbidities. So looking at the vaccine distributed versus vaccinated, now when we are looking at about 5 months in, after the vaccination has started, as of April 18, 500,000 people have been vaccinated. So that's as a performance is low, like it's 24% out of total. And when we look at the total overall acceptance of the vaccine, because I don't have an aggregated data, but from some information from Ministry of Health and other colleagues that are on the forefront of delivering the service, there has been different uptake, acceptance of the vaccine within healthcare providers and support staff, like maybe 50%. And then even within the healthcare providers, you see more reluctance with, for example, nurses and so on. And of course, other beneficiaries, even less than that, because as you can see from the overall total vaccinated, it shows how much acceptance there is. So, sorry. The issues that I wanted to point out today is more of vaccine equity, because COVAX, among other initiatives, was with the aim of having equitable, distribution of vaccine when it's ready. So it's really a very unique solidarity, worldwide solidarity, which should be appreciated. But in reality, when we see now, the reality speaks otherwise, because the vaccine distribution, as you see, and the access is very much disproportional over the world, meaning the globe, the whole world, having more than 800 million vaccines that have been administered in low-income countries. Only less than 1% is being distributed and accessed. So even within countries, then we have to prioritize and give only for those who are, prioritized. So the vaccine distribution, access, and the inequity that is being, in reality is being seen is something that we have to discuss on. And then going on to vaccine options, because now the vaccine that we have is AstraZeneca, and you know that we have a lot of, not a lot, but reports of, side effects, and we see different countries are taking different options. Some are stopping it, some are, using it for certain age groups and so on. And then when we come to low-income countries like Africa, where most of the people are young, and then what options do you have except to use what you have? So these are also, I think, challenges that institutions, people are navigating around. And the other thing is about vaccine hesitancy, because as you saw, our distribution and uptake and acceptance is, low. But as I said, because it's not evidence-based, but we can attribute it to maybe hesitancy or operational difficulties or this slow decision making. People are deciding later on how to to get to the vaccine, because from what we have discussed with different people here, people at the beginning were more reluctant, and later on will be, depending on colleagues, peer pressure, and so on, have been vaccinated. And then we have also other people who are still hesitant, but it might be different. Because there are different factors that make people, decide about vaccine hesitancy. And then when another ethical challenge that I see is especially when you have that hesitancy as a healthcare worker, and then looking at why you are getting vaccinated, because what COVID has shown us is not only with vaccine, but even with the healthcare measures that we are advised, that we are not thinking only about ourselves. We are thinking about the other person. We are talking about the community. So are you withholding your role in, your contribution to herd immunity, by refusing vaccine and so on. And then another, tension will be when you have vaccine scarcity. So how do institutions in countries like ours advocate for acceptance of vaccine? What if the demand becomes high? Do they have the vaccine to give it? So I think that is one dilemma that our institutions are struggling in decision making and so on. And then again, one thing I wanted to talk about on vaccine equity also is about access. Distribution is going back to the previous one. Really, I was looking at, we all are, of course, following up the news and looking at, at the beginning, people knew that there will be scarce the amount of vaccine. And it was, understandable that people were, governments were buying a lot of vaccine and having excess vaccine. So luckily, 4 vaccines were developed that were, more than that anyways. But even then, when you hear that some countries have 2 times to vaccinate their population, or they have a lot of surplus of vaccines that they are holding. So this, I was thinking that the world has been locked into it is this scarcity mindset, because when you have enough surplus, why aren't you giving it to those who deserve it, those who need it, not that kind of thing. So I think the scarcity mindset is very important. That's what the world is in, because we are afraid of the unknown. So because it's scarce, we are holding into surplus. But again, it shows about the current rate of vaccine administration and the impact on developing countries and the world at large, because we are, because of the inequity of vaccine distribution, access, and administration, we are letting the disease, go on, the pandemic, go on in these countries where people are under vaccinated, and this is a threat for global health in a way, that because when we have that withholding of the opportunity to vaccinate people, we are letting the vaccine have these variants which will be difficult to, even for the vaccines that are now being used. So when it is said no one is safe unless everyone is safe, I think it's really something, it's beyond the slogan. It's something that has an impact on how we are administering vaccines and how the impact is on developing countries and the world. So I think I'll stop here and maybe have more of on the discussion part. Thank you.
Thank you very much.
Back to you.
Thank you very much, Yimtu, for sharing with us about the situation in Ethiopia. You have raised so many interesting and yet difficult issues. So we are going to discuss those issues later when we come to the question and answer segment. So now I would like to introduce our second panelist. In the meantime, I think Kathleen, you can go ahead and share the slides for our second panelist. So our second panelist is Dr. Bartholomew Dicky Akarmori. We popularly call him Dicky. So he has served as the regional advisor for vaccine research and regulation in the World Health Organization Regional Office for Africa, which is based in Brazzaville, Congo. And he has been there since 2007. And right now in Brazzaville, the time is 5 o'clock p.m. And in Addis, it's actually around 7. It's after 7 p.m. So we thank these two colleagues for taking their time during the evening to be with us. So Dicky is responsible for vaccine research, regulation, and safety. And he leads a small team at the Secretariat of the WHO AFRO. So this is the Secretariat for a small organization which is called the African Vaccine Regulatory Forum, or AVRF in short. So during my previous life, when I was working in Africa, I was actively participating in the activities of AVRF, and I hope he's going to talk a bit more about AVRF and its role in terms of improving access to medicines, safe medicines. So Dicky holds a PhD in immunology, and before joining the WHO, he was serving as a professor of immunology at the College of Health Sciences at the University of Ghana. He has been conducting research back then into infectious diseases, including clinical trials for vaccines against malaria, meningitis, and also measles. He has published widely and is currently working on supporting capacity building for regulatory and ethics oversight capacity across Africa through AVRF. He also serves as a reviewer for the WHO AFRO Ethics Review Committee. So over to you, Dicky. Dicky, you are still muted. Dicky, you are still muted. We can't hear you. Hello, Dicky. I'm just hoping that his internet is not frozen.
Yeah, Paul, are you able to ask him to unmute? Because I tried to click the button, but it doesn't seem to work for me.
Yeah,
As your co-host.
I'm clicking the button here to ask him to unmute.
Okay.
Yes.
Now we can hear you.
Can you hear me?
Yes.
I think we're we're having difficulties. I was having difficulties muting. But thank you very much, Paul. I really appreciate this opportunity to be on this panel for this very, very important webinar. I'd like to thank you and to thank the university, and of course, to thank BIG for this opportunity. And thank you for those very kind words about me. Now, what I've tried to do, the next slide, please, is to give you an overview of where we are with vaccine rollout in the African region, give a regional perspective. We have had a very, very interesting presentation from Ethiopia and where they are. And indeed, some of that information is contained in this. And the point I want to make here is, you see this first slide shows you the very first jab which was given in Africa of any COVID-19 vaccine. This was given to the president of Ghana, His Excellency Nana Addo Dankwa Akufo-Addo. And I think that this speaks volumes. It was a day we were all very, very excited as Africans that despite all the delays and despite all the negative things said about vaccine nationalism and the fact that Africa may not receive vaccines, we did finally receive COVAX facility vaccines, and immunization began in earnest, and you will soon see where we are with respect to the vaccination. But I thought that for this meeting, and the next slide, please, as bioethicists, I think it will not be, I won't be doing justice to this if I did not touch on, if I didn't touch on some elements of ethics. Wow, there's something on my screen I want to get rid of. Let's see if it goes. Yeah. So I thought I'll begin with some background. So the primary objective would be, so we have time for discussion, would be to give a brief background. Then I'll talk about the vaccine rollout, and I'll look at the challenges, the issues that we are facing on the African continent. So the next slide, I think that we all know, and I'm sorry I'm preaching to the converted, that the key principles of ethics are not just meant for research, but that these are fundamental to any public health action or implementation of interventions. And these primarily are that we should do good, we should not do any harm, we should ensure there's justice and there's fairness. So these principles have underscored every action that WHO has taken with respect to the response to COVID-19. The next slide, please. And I want to underscore this because it all began with ethics. So very early on, the WHO ethics and COVID-19 pandemic response started with a working group which was constituted to advise our member states, but also to advise the technical departments and guide the work of these technical departments in addressing the pandemic. Among other things, they provided guidance for the ethical consideration for research. They provided a publication to guide research in general, clinical management of COVID-19, the famous solidarity trials you may have heard of, which were initiated with the support of WHO to ensure that therapeutics and vaccines could be developed very quickly. Then, of course, they were also involved in resource mobilization and priority setting, and they also help to ensure that some issues that are being discussed now were actually considered early, such as immunization certificates or immunity certificates, and the monitored emergency use of experimental products, i.e. vaccines and therapeutics. The next slide. Now, among other things, they also provided guidance for the predecessor to the COVAX facility, i.e. the access to COVID-19 tools, the ACT accelerator, a partnership between WHO, CEPI, Gavi, and UNICEF and others to ensure that vaccines and therapeutics and diagnosis could be developed and access would be equitable to everyone, regardless of where they live or who they are. They also provided, we set up an international working group that helped to develop a framework to support the work of the ACT accelerator and eventually of the COVAX facility. The next slide, please. So the reason I'm taking the trouble to do this is because I want to put things into context and for us to all understand why. Now, why ethics in all of this? Ethics because for every public health activity, ethics is fundamental, especially to equity and access. You cannot have equity in access unless you address ethics, unless every individual benefits from an intervention and any scientific work and its output. You cannot have any ethics unless there's safety for the products which are used under the principle of doing no harm. You cannot have equity unless there's fair pricing for products, for different products. And finally, justice is essential to giving people the power and their right to choose whether it's treatment or it is prevention. The next slide, please. Now, just to add that the development of these vaccines has gone on at a fantastic pace. We have never in the history of research and development been so lucky that out of a handful of platforms, technologies, and within a period of 10 months, we have ended up with 4 different types of vaccines which work against one disease. This really is the pinnacle of research and all the investments that have gone into it. And the WHO ethics committees have helped to shape some of the work by ensuring expedited review procedures are in countries. And Paul referred to the African Vaccine Regulatory Forum, and I have one slide, which is the next one, to address this, but to show you that the African Vaccine Regulatory Forum is a platform that brings together regulators and ethics committees, and to ensure that they provide all that is required to expedite research and development and access to treatment and prevention of illnesses in Africa. And we have learned a great deal from previous epidemics and pandemics, particularly the epidemic of Ebola of 2014, because AFRO served as a connector for the 55 countries, bringing their regulators and ethics committees together, ensuring that they were able to help develop vaccines against Ebola. But before that, we worked to develop a vaccine against meningitis, and now epidemics of meningitis are rare, malaria, tuberculosis, and now COVID-19. The next slide. And for COVID-19, the target immediately was to approve a competitive timeline for product development. One which respects the frameworks for countries, one which is also transparent, that helps to ensure that reviews take place, that under very good governance, and that countries are able to address clinical trials with a turnaround time of 10 days for products which are being proposed, such as the antivirals which were being tested against COVID-19, and for novel products, 15 days, including vaccines. Next slide. Now, having taken you through this, now let me tell you where we are with vaccines, because we have since gone through, cleared the hurdles, and as I said, we have vaccines in place. So currently, we have 47 countries, a total of 47 countries in our region which have received vaccines of any type, of any kind. We have 41 which have received vaccines under COVAX, and you already heard from the number of doses that Ethiopia received. We have 12 countries which have also received vaccines from the African Union through what we call the African Vaccine Acquisition Task Team, or AVAT. And finally, countries obviously have also negotiated their own bilateral arrangements to secure additional vaccines, and that number is 33. Now, in the next three elements of this dashboard, and by the way, this is a dashboard which has been developed, available publicly, and it gives you the numbers as we update them daily. You have the total number of doses of vaccines which have been received. 34 million doses have been received. 80 million for COVAX, 975,000 for AVAT, the African Vaccine Acquisition Task Team of the African Union, and 14 million secured through bilateral arrangements. The number of countries which have started vaccinating is also provided in the next row, and you can get all the details there. Now, the next couple of slides quickly, next slide, gives you the same picture, but in the form of graphs, in the form of maps, I beg your pardon. So you can see several countries are sourcing vaccines, additional vaccines, to help them meet this global shortage, either through bilateral arrangements or through the African Vaccine Acquisition Task Team. And this map just summarizes that information. The next slide, please. Again, you look here, what are the different vaccines in use? There are several vaccines in use on the continent. These are all the vaccine types which are being used. But let me say that the majority of countries are using AstraZeneca. And AstraZeneca comes in two forms, or it's the same vaccine. There's the COVAX facility AstraZeneca vaccine, which is from Serum Institute of India. And then there's AstraZeneca from SK Bio of Korea, which is for countries which are self-financing. To the left, the graph provides with all the other vaccines and combinations of vaccines that are used in countries. As you can imagine, and even from the global point of view, because of shortages of vaccines, there's no luxury of saying you will limit yourself to just one type of vaccine. The next slide, please. Again, this gives you a picture of the ratio of vaccine doses received per 100 people. And I'm sure for you, those who are in the US, those who are in Europe, and other countries, this may look almost a bit low, because you're talking there about millions and millions of doses. But if you look at the ratio, it's important to note that there are countries which have such high ratios per 100 population. And these are mainly the small countries, Seychelles, Mauritius, and also the countries which started early. But you see, the majority of countries, the number of doses per 100 people is very, very low. The next slide, please. Again, to give you a breakdown in another form, here we're talking about 15.4 million doses which have reported to have been administered in Africa. So from the data that we have, 15.4 million doses have been administered. But this could easily be the number of doses administered in one part of the United States only. So you can imagine where Africa is lagging behind. But nonetheless, the countries are doing their best. 45 countries have started, vaccination, as you can see with this number of doses. And we still have 39 countries which have received COVAX facility vaccines and which have started vaccine. So we have the overall picture to the left, and to the right, we have the COVAX vaccines. The next slide, please. Again, to give you an idea what is happening, this is the ratio of vaccines which have been administered over the vaccines which have been received. And as has been mentioned in Ethiopia, the very few countries have really vaccinated large numbers of their populations. Most countries haven't been able to do this for a variety of reasons, which I'll come to in the end and which will form part of our discussions. Next slide, please. And I don't want to speak for too long. Again, just some of these statistics, and you can get access to this dashboard, and you can access the same information and see, again, the ratio of first dose administered per 100 people. And the next slide, which will tell you the number where there's complete immunization, because as you know, most of the vaccines which are being used on the continent are 2-dose vaccines, with the exception of South Africa, which is using the Janssen and Janssen vaccine, which is a 1-dose vaccine. So clearly you can see countries have done a tremendous job with the first dose. The second dose is still low. Some countries you can see have barely started, and that's because they received the vaccines only in the last couple of weeks. And there are also other reasons, such as the operational costs that go with vaccine introductions and so on. The next slide, please. Right, so this summarizes the countries which are reporting on vaccines of, countries which are reporting vaccination of priority groups, because as you know, the priority groups are health workers first, then followed by other frontline workers. Then of course, some countries have also added other categories. And then we have the elderly beyond the age of 60, 65, depending on where you are, which country. And this just gives you a flavor of how we are doing with respect to these priority categories, because it's very important that we address the priority groups in line with the whole strategy of vaccination as we progress towards what we hope would be creating herd immunity. The next slide, please. So, having gone through all these, I thought I'll summarize some of the challenges we are facing. Clearly, there's a slow uptake, and for a number of reasons. Then we have operational funds or costs, which accompany vaccine introductions under normal circumstances through Gavi, where countries also receive some money to address the operational costs of of delivering vaccines. Then we have data, and we keep saying data, data. We are really appealing to countries to provide data for this dashboard. That's the only way we will have all the data in one place, and we can appropriately respond to the needs of countries. And especially the reporting of adverse events following immunization, or AEFIs. And finally, vaccine availability is also a huge challenge that must be addressed. And I'll stop here so we can have some discussions. And I want to thank you again, Paul, and thank you very much for this opportunity to speak on behalf of AFRO.
Thank you very much, Dicky, for your talk. You've taken us through all the work that you are doing as WHO AFRO, particularly focusing on what you are doing in terms of implementing the ethical principles, and also touching on the role of the WHO in guiding COVID-19 research. But more importantly, I liked your emphasis on reducing the timelines that investigators, have to go through when they are requiring the approvals for trials. You mentioned the 10 days and also 15 days. If that is achieved, that would actually be great, because lots of investigators are always complaining about 6 months that it takes, and 9 months, and so forth and so forth. So thank you very much for giving us a picture of what's happening in Africa. So now it's time for question and answers, and I see that there are some questions that are being posed right there in the chat function. I want to start by posing a question to Yimtu. And Dicky, can you just keep yourself unmuted? And Yimtu,
Yes.
yeah, and Yimtu, just keep yourself also unmuted. So, Yimtu, you mentioned that you've received, as Ethiopia, 2.2 million doses, and yet only 500,000 have gone into arms. What are the real issues?
Yeah, that's a good question, because I was discussing with people with them in the ministry also, because they don't want to attribute it to vaccine hesitancy, all of it. But because, as I said, there are some studies ongoing, and there is also a study on vaccine hesitancy, but it's in preprint stage, so I don't want to quote that. But overall, there might be many factors for that. Starting with, of course, there will be vaccine hesitancy because of the misinformation in myths and so on and so forth. But again, it could be operational difficulties, or slow decision making on the people that are being offered the vaccine. Because according to the ministry, the 2.2 million vaccines have been distributed all over the region. We have 10 regions and 2 administrative cities. So it has been distributed according to the data, but because of different reasons, they have this low uptake. But they are doing, I think they are continuing to do, to make an effort to have everything in the arms, the jabs. Yeah.
No, I think you're absolutely right. And I think, just to add a couple of comments to this, I mean, it sounds very simple to say that you've got vaccines, people come, they receive the vaccines, and that's it. But it's not that simple, particularly because you are prioritizing the vaccination. That's one. Secondly, you are having to deliver vaccines to adults and not typically children, where mothers can come and wait. Thirdly, you are doing this in the context of a pandemic, which is still ongoing, and you need to fulfill all the measures. And so it requires a lot of planning and the operational aspects are huge. And I think we also need to understand that because of this large rollout, you're going to need additional people to vaccinate because they're vaccinating health workers all over. And so you're going to need additional people who need to be trained, who normally are not even delivering vaccines, but now you're having to get them to do this. For example, South Africa had to engage 600 pharmacists to help address this. And you also need to identify the priority populations, and it's not easy. Health workers, they'll come to health facilities, but the elderly, those with comorbidities, it's not easy to find them quickly, and you need to register everybody who receives a vaccine so you can track who receives a vaccine. So all of these operational considerations, I think, were underestimated, but clearly the countries are doing their best to address this, and that's why the pace is rather slow. Thank you.
Thank you very much, Dicky, for the additions. There is an interesting and challenging question here, and I will direct this to Dicky. How do you see the suggestion on making the COVID vaccine mandatory for all health workers for the sake of their patients, despite significant hesitancy from health workers?
Oh, thank you very much. That is actually a very important question, but the answer is simple. You cannot make it mandatory. I think we need to put everything into context, and particularly speaking to bioethicists, as I said at the beginning, people have to have the choice. Remember that individuals who receive vaccines are otherwise healthy people. It's not treatment. It's to protect as many people as possible. And again, the basis of immunization is to immunize a critical number of people that would help to increase the barrier to transmission and help to lower transmission and keep everybody safe. So clearly, you cannot make it compulsory and say health workers must. I think what we have to keep doing is we have to keep explaining and reaching out to the health workers and making them understand that they are at risk, particularly if you're a health worker, you have some existing or some comorbidity. It's better for you to be protected than for you to get the disease, because it could lead to complications that could affect or alter your life forever. So I think that the simple answer is that we continue to advocate. We use some of the champions, the health workers themselves, as champions to champion the whole process of receiving a jab. And I think we'll get there. Thank you.
Thank you, Dicky. So you have basically also responded to the other question from one of the participants. There was asking the question, are the regulatory authorities discussing mandatory vaccination of our populations? So I guess that would also be your response to that particular question.
Absolutely, absolutely, yes, absolutely. And immunization generally is not, you don't enforce it. You give very good reasons why people should get vaccinated, and you rely on the fact that they would see that as health workers, they are there to promote the well-being and the health of the people that they serve and care for. And hence they are supposed to be torchbearers. They're supposed to be good examples. And I think that that message will keep resonating. And if it keeps resonating, I think we'll get some good results.
Thank you very much. I'm going to address my next question to Yimtu. So in fact, I'm going to pose two questions to Yimtu. One of them is, can you comment on religion and vaccination in Ethiopia? Is religion actually impacting in any way on vaccination in Ethiopia? So that's the first question. And then the second one, I would also want you to look into the issue of the recent reports concerning the AstraZeneca vaccine. You said that in Ethiopia you are relying on the AstraZeneca vaccine. And what has been the impact of the recent reports in Ethiopia? Because here in the US, we are also looking into the issues around the Johnson & Johnson vaccine, and the FDA has placed a pause on its usage. So comment on what's happening in Ethiopia.
Okay, thank you. So for the first question, whether religion has an impact, again, I don't have such, extensive study where the impact is shown, but from personal, interactions with people, they attribute it to, I don't know if you know the 666 number, something like that, in religion, yeah. So people have that needs, which, are asking, even personally, I've been asked, do you believe that it could be that, and I was responding that it couldn't be, because knowledge is from God. So, this kind of replies and trying to address this kind of situation. So in a certain way, it might. And there are people who are saying that, of course, and there is widespread talk about some places where they believe that nothing can touch them, only God will protect them, and they don't need anything. So I don't know how widespread it is, but it is there. It has an impact. So, and looking at the second question, I remember that the reports started coming in about the AstraZeneca exactly the week that the vaccine was being launched in Ethiopia. So, I mean, that's why I raised the vaccine options, people know this. It's already known that there is some data, even though it's very scarce, and countries who have the luxury of putting, choosing the vaccine or stopping it, or, having ages that could use it or not, have the luxury of having other options. But I think we didn't have any options. Maybe it has some role in the acceptability of the vaccine. That's why I said that we really need to study the reasons for the the slow uptake, like 24%. So it might play a role, because people are, the social media, everything is accessible, so people are being informed from that. So, but apart from that, we are just going on using it, and whoever is accepting it is being vaccinated. So do we have a choice? That's my question.
Thank you. Thank you. My next question is going to Dicky. You're actually involved in the thick of things when it comes to negotiations on behalf of Africa. So how is WHO going to insist on equity in vaccines for Africa from high-income countries?
That's an excellent question. That's an excellent question. And in fact, I think that the background that I actually presented tells you the effort that WHO put into this entire response. Right from the beginning, as far back as February, we recognized that there was a need to address equity and to address it from its fundamental roots. And we haven't stopped addressing equity. And we have continued with the Director General, our regional director for Africa, and all the leadership and staff of WHO are consistently sending out the same message that we cannot deny those who have no access vaccines. We cannot take Africa and put Africa at the end of the queue, and that countries have to definitely ensure that Africa has access to vaccines. Because the only way we are all getting out of this pandemic is if we are able to vaccinate all populations and with no exception. And I think even the moral justification is missing for a country to say, well, we only think we're thinking about just our population because we have the money to buy up all the vaccine. We are the ones who developed the vaccine, therefore we are entitled to it and our population is entitled to it. And others who are unfortunate not to have the capacity to do so should not have vaccines. I think that that's absolutely, absolutely untenable and something that should not happen. So, one, we are not only appealing to and working with countries directly, we are also ensuring that through the COVAX facility, every effort is made to look at every supplier who has vaccines to ensure that there's access to vaccines on the continent. Of course, making sure that these vaccines go through due diligence with respect to regulatory assessment and approvals so that we are giving the right products to our populations. So we are leaving no stone unturned in the effort to address this. We know that there will always be inequities in access to health. I mean, if you compare our health systems to health systems elsewhere, in developed countries, they are not the same. But when it comes to COVID-19, I think we are doing everything we can. And we are also getting champions. The leadership of the continent itself, the heads of state are also pushing very hard. And above all, there are also other philanthropic organizations which are also helping to support this effort. Thank you.
Thank you very much, Dicky. We are now running out of time, so I'm going to give Yimtu 30 seconds to give some closing remarks.
Thank you. That's even saying my name will take up the 30 seconds. Anyways, thank you so much. So what I wanted to say was, I just want to reiterate what Dicky said, that, what has been started by COVAX is really commendable. That shows the unique solidarity of the world, but countries have to really believe in it and then act on it, because what has been done is good, but we are far from attaining what we wish. So I hope WHO will continue pushing it, and then the countries will also wake up and believe in it and act on it. And in addition to that, I think it's very important to the community engagement with vaccine is very important. I think even with what we have to increase the uptake and so on, that would be very important. Anyways, so thank you so much, and I hope we'll hear good things going forward.
Thank you so much, Yimtu. I'll also give Dicky 25 seconds.
Oh, thank you very much. That's very generous of you, and I will be very brief. I think to add on to what Yimtu has so beautifully summed up, you as a voice can also reach very far. And I think that your voices can also help to address this inequity that we are seeing, because you may not, fully appreciate it, but what you say and discuss in different parts of the world, especially in the US, in other rich countries, can also make a difference. And finally, we are not out of the woods yet. We should never make the mistake of thinking that these vaccines will solve the problem instantly. We still have a long way to go. And I think we should continue to respect the public health actions, wear masks, safe distancing, do all the things that we're doing right and not get tired of it. That's the only way we defeat this disease. Thank you very much.
Thank you very much, Dicky. So once again, I would like to thank our two panelists, Yimtu for sharing with us the experience at country level, that's Ethiopia, and Dicky for sharing with us the views at continent level. So thanks to you two colleagues for taking your time to talk to us. I would also like to take this moment to thank everyone who has participated in this webinar, and thanks for all those comments and all those questions. So let's meet again during our next webinar, which is going to be on the 25th of May. Goodbye.
Bye. Thank you.